Hello and welcome to the Desira Clinical Education Oncology podcast. I'm your host, Jervis Constanzo. Today's episode features Dr. Cristina Saura from Vall Universita Hospital in Barcelona, Spain, and Dr. Giampaolo Bianchini from Ospedale San Raffaele in Milan, Italy. They will be discussing practical approaches to PI3K pathway testing in metastatic breast cancer, emerging evidence for PI3K and AKT pathway inhibition, and treatment sequencing after CDK4/6 inhibitor progression. This episode is part of a larger educational program titled Novel Targeted Therapies for PIK3CA, AKT1, PTEN altered metastatic breast cancer, Key Evidence and Real-World Insights to Optimize Patient Care. For more information on Drs. Saura and Bianchini, along with a link to the larger educational program, please visit the show notes for this episode. Now let's hear what the experts have to say about this very important topic.
Hello, everyone. It's a pleasure to be here today for this podcast talking about the clinical needs around the PI3K pathway for patients with breast cancer. It's my pleasure to be in this conversation with Dr. Bianchini. Let me start introducing myself. I'm Cristina Saura, a breast medical oncologist working at Vall University Hospital and VHIO in Barcelona, Spain. And Dr. Bianchini, please, could you introduce yourself?
I'm Giampaolo Bianchini. I am a breast medical oncologist working in San Raffaele Hospital in Milan.
Perhaps we can start where we position this treatment for our patients and when we consider to test the patients for these pathway alterations. Perhaps we can start from there. In your clinical practice, Giampaolo, where do you test your patients? Do you test the patients in tumor or in liquid biopsy? And if in tumor, are you using the primary tumor or the metastatic samples?
So that is a very good question. We adapted in the last year to make a practical approach. So what we decide to do, but I think there are other approaches that can be used, is we test all the patients in first line on the tissue for the biopsy, the metastatic or archival tissue. Just to remind that it's not impossible, it's not frequent to acquire PI3K alteration. So we usually do a test for PI3K, AKT, and IRCCS. So we do a somatic to potential reflex for when we found an alteration in the tissue to eventually confirm it's germline or not. And then at the time of progression, we do the liquid biopsy. That means we have the possibility to test for ESR1. And of course, there is also the possibility to capture some emergence PI3K or AKT10 cannot be captured in the liquid biopsy. And what you do in your practice?
As you, we change our approach based on the data of the INAVO120 trial because a few years ago, we test all the patients at progression after the first-line setting of CDK4/6 inhibitors because we understood that in that situation, we don't have the option to treat the patients up front with PI3K or AKT inhibitors. But as we change our clinical practice based on the data of the INAVO120 trial with an overall survival benefit to be able to identify those patients upfront that may be PI3K mutant to discuss with them the opportunity to treat them with PI3K inhibitors with the triplet. And like you, I fully agree that it's important to test also the patients at progression of CDK4/6 inhibitors using the liquid biopsies to capture the ESR1 mutations. And about 10% of those patients with no available tissue or without mutations at the beginning in PI3K pathway that may appear as a mechanism of resistance. So very similar practice in Italy and Spain today. Based on that, do you have the opportunity to offer your patients inavolisib in the first-line setting, or you are only treating those patients up front with the triplet in your practice? And if this is the case, which patients are you considering for the triplet up front?
I realized in the meantime I was talking that I was strongly influenced by my practice activity. Unfortunately, we still are waiting for the reimbursement of inavolisib in first line. That's why I didn't mention, because of course, in this situation, there is no, need, just because we don't have the therapeutic opportunity. As soon as we will have inavolisib available, to be totally transparent, I will test all the patients that could be candidate. So the only patient that I will exclude are the patient with frank diabetes or with contraindication to start inavolisib. But and when the clinical judgment make for me inavolisib not a suitable option. But for the majority of the patient, I will say I will test and I will offer the combination. We are talking about endocrine resistant patients, so primary and secondary, so population that is hard to treat. And again, for me, the data are really convincing, and I will implement the testing in a broader way as soon as the drug will be available.
Yeah, thank you for sharing your experience. You touch an important issue, that it's the definition or the population that we consider in that space of the first line setting, and in the ESMO guidelines, it's already included the concept of patients with endocrine resistance. And as you mentioned, we do have the evidence of adding inavolisib as a triplet therapy in combination with palbociclib. But you know also that different clinical trials are testing benefit of the triplet in endocrine sensitive population. There are ongoing trials recruiting patients with inavo and also with the allosteric PI3CA inhibitors. We don't have data there. Do you think that we will see the same benefit for those patients with endocrine sensitive disease? Or perhaps it may be enough for those patients to treat them with a doublet and consider the PI3K inhibition at progression? We don't have data, so it's just an opinion.
You say you provide a really broader view. The PI3K pathway is not just relevant. We have many options to really target the pathway. And we are enrolling in the NAVO123, that is, for instance, exactly offering inavolisib in the endocrine sensitive population. And now there is also the possibility to use ribociclib. That, in my opinion, is the CDK that I would prefer also for the standard arm. My expectations are for sure positive. There is, we know that PI3K mutation in metastatic, not in early setting, is associated with poor prognosis. So even in the endocrine sensitive, this is a population more in need. And having a target and provide the opportunity to target the triplet, so to really target at the same time the endocrine, the CDK, and the PI3K pathway, to me is something that is just more than using two drugs. It's really using the synergistic effect that there are among the drug. We start to have several PI3K in the market, and also the results of the trial. Can you comment about what the future, if there is, for alpelisib, that in the past was not just possible to use it, but now Victoria-1 trial, for instance, really is the first trial that provides some evidence of direct comparison. Can you put a little bit in context about really the evolution of the opportunity to target the target with, say, evolving drug?
I think that the history of alpelisib, it has been really unfortunate, because in many countries here in Europe, I don't know exactly the situation in Italy, but in Spain, although we had the approval from the European Medical Agency, we only have the opportunity to treat patients with reimbursement in the public system if patients have not received CDK4/6 inhibitors, that at the end of the day became the standard of care for most of the patients in our clinic. So really, we've treated a very low percentage of patients with alpelisib. Said that, I think that the pathway started to have more importance because alpelisib, another issue that was very important, it was the tolerance, the hyperglycemia and other toxicities like the rash really limited the tolerance of the patient in the clinic. And I think that the more advanced PI3K AKT pathway inhibitors are really increasing not only the efficacy results, but also the tolerance. Regarding gedatolisib, at ESMO, we've seen the results for the PI3K wild-type population that were impressive at that time. And at ASCO, we've just seen the results for the PI3K mutant population. And as expected, the median PFS was really impressive in that situation for patients progressing to CDK4/6 inhibitors with median PFS around 11 months. I was surprised about the median PFS very similar for those patients treated with the doublet or the triplet. And I'm still willing to see more details on the clinical trial to understand this very similar median PFS, probably related with discontinuations or interruptions or the reductions. But this is a detail. Anyway, gedatolisib, it's an important drug. I think that they will send a file to the FDA for approval. Perhaps the main limitation with gedatolisib is first the IV administration, because I think that in that space where the patients are still endocrine sensitive and able to be free or far from the hospital, to give them an oral therapy, it's important. And the second issue, it's the mucositis, that it's not grade 3 or higher. Most of the mucositis are grade 1 or 2, but this may be something that can limit the applicability of this drug in the clinic. Perhaps you can comment about other PI3Ks that are also in development, the allosteric ones. You know that zovegalisib and tersolisib are PI3K inhibitors that we have data from the phase 1 trial, so very limited data, not a lot of patients. But what do you think about the safety and efficacy profile of these two drugs? Because both of them have the phase 3 trials running and recruiting patients.
Yeah, I would like to start a little bit with inavolisib, because what really impressed about the INAVO120 was the tolerability of inavolisib in a triplet. And just to remind to who is listening, that's a very different situation compared to the triplet used in the Victoria one, because this was, in the Victoria one, the treatment was a post-CDK scenario. In INAVO120 was, we say, not exposed to CDK scenario. So is in some way, Palbo in that trial was a continuation of a CDK. But to come to INAVO, again, in that trial was not a direct comparison with alpelisib, but we was very happy about the overall safety profile. And just to remind, we have the INAVO121 that is a very clean and similar design to the Victoria to test inavolisib plus fulvestrant compared to alpelisib and fulvestrant. We will see probably the results very soon. And I think this is important. But as you mentioned, there is a new generation of PI3K coming that target PI3K in a different site, in a different position of the molecule, with the capability to spare the wild type PI3K in a manner that is remarkable. So both zovegalisib and tersolisib have a good safety profile by the data that are available so far. Some are in poster, some are press release. The Rediscover 2, that is a phase 2 trial, is ongoing comparing to capivacid. So the bar is growing, in my opinion, in terms of both the tolerability of the comparison and the efficacy. And so I really like that we are moving from just targeting the pathway to target the pathway with a better way to target the target. So I really like the evolution that taking advantage of what we understand about the biology. And what you think about in general about the selection of the PI3K when you have a co-mutated patient, so ESR1 and a PI3K mutation after CDK? What you do in your practice?
In my clinical practice today, I offer the patients the best treatment available at our sites. So most of these options are offered in clinical trials. So the ideal scenario is to offer a combination with a SERD plus a PI3K inhibitor, and we do have several clinical trials with different cohorts in phase 1 offering that combinations, and we try to offer those patients these kind of combinations, sometimes also using CDK2 or CDK4 inhibitors as triplets. So I think that we are now building the evidence to understand which could be the best option for those patients. We published a meta-analysis led by Guillermo Villacampa that did in cancer review treatment, and we analyzed all the data published with different drugs in that specific scenario that you mentioned after CDK4/6 inhibitors. And interestingly, we went to this specific population of patients with PI3K and ESR1 mutations. And from that meta-analysis, with all the limitations that may have this work, we've seen there that the best options or the options offering longer medium follow-up was the combination of fulvestrant plus a PI3K inhibitor or a SERD plus a CDK4/6 inhibitor. Nothing new. We have data on these specific scenarios, and I think that this will be the evidence that will be growing in the next few years. I don't know if you have a different approach to these co-mutant patients in your clinic.
You mentioned the clinical trial, but you are in a big center, a reference center. You are lucky to have a clinical trial. And thinking to the community in which is not always possible to offer clinical trial, I would say my key element to define are first the time of CDK in the first line. So I would never offer a Elarcistan monotherapy that is available in Italy if the progression happened in the first 12 months. With really, really rare exception, because we know that in this resistant patient, Elarcistan is really not working. In this area, instead, the capivasertib, because it is the only PI3K actually is an AKT inhibitor, but target the PI3K pathway by targeting AKT that is just below in the pathway to PI3K is available. I treat this patient where we have actually good results, and also the Capitello 291 that set the space for capivasertib demonstrated similar activity in primary and secondary endocrine resistance. So for PI3K, there is not a big separation. For the patient that progress after 12 months, usually I look at the burden of disease. If the burden is not huge, I don't have an urgency of response rate, I prefer monotherapy with Elarcistan because of the tolerability. I strongly and close monitoring the patient. The first TC always at 2 months, never more than 2 months. I check if there is a response or not, and eventually I change it. For instance, I can offer a KT. Otherwise, I prefer capivasertib starting and then switching for Elarcistan. A question to you is, when in this space you use ADC, chemo, so you don't go for an endocrine option, which are the guide for you to decide that is better to go for something else?
We try to treat the patient with endocrine therapies, normally in combination. As you mentioned, we after progression to CDK4/6 inhibitors, it's very limited the number of patients that we may offer monotherapy with SERD. The criteria that you shared is the same that we can use here. And we try to continue endocrine therapy-based treatments for all the patients that at least has a benefit on the previous line of therapy of more than 6 months. And of course, for those patients that derive benefit more than 12 months, we really try to find an option of an endocrine therapy-based. Our threshold or our criteria to move to chemotherapy or ADCs in the first line setting are definitely the endocrine resistant for those patients. So when the progression is less than 6 months is when we consider the option of using ADCs in the clinic. And perhaps with this, I don't know if you use the same criteria in your clinical practice.
Yeah, our approach is really, really very similar. And I think that this is really reasonable for the clinical practice. So may I suggest you to give a few takeaway from the discussion that we have had together?
Sorry, perhaps the first takeaway could be for our audience is to consider when and where to test the patient. And as we mentioned before, I think that the primary tumor or the metastatic tumor is a good tissue to test the mutations. And at progression of CDK4/6 inhibitors, the liquid biopsy, it seems to be the best way to test the patients to capture not only the PI3K mutations that may arise, but also the ESR1 mutations. The second topic or the second takeaway messages from me is that targeting the PI3K pathway for patients with luminal disease, it's really meaningful for those patients. And we have now data of impact in overall survival, offering the triplet for those patients upfront. And we can consider that option of the triplet upfront or at progression of CDK4/6 inhibitors. And the third message from my side is that the field is evolving very quick. We have a plethora of drugs that are giving to our patients very good news because the efficacy is improving with better drugs, Inavo, Zovegalisib, Tersolisib, and with a better safety profile that definitely are improving quality of life of our patients. Perhaps you want to add something else to these messages, Giampaolo?
I think you summarized very well. The only thing that I will tell my colleagues is, we in the past consider enough to decide how to treat metastatic breast cancer because we have ER positive, HER2 status, and maybe the HER2 low or ultra low status. Now, I think we should enter in the idea that we need to know the PI3K pathway status. Is something that in the metastatic, we need to know upfront because it is part of our tailoring decision. And if we do this really as a scientific clinical exercise, we will be able to use at best the opportunity coming from enrollment in clinical trial, availability of drug, and the potential to use them. And just remind, PI3K pathway is not just PI3K. AKT and 10 are very important. 25% of the alteration in the pathway are related to 10 and AKT. And really, I would like to thank Cristina and all was listening. Was really a nice discussion.
Thank you.
Thank you, Drs. Saura and Bianchini, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Novel Targeted Therapies for PIK3CA, AKT1, PTEN altered metastatic breast cancer, key evidence and real-world insights to optimize patient care, please visit the link in the show notes. As always, thanks for listening.